I'll welcome everyone back to the Stem Cells from the Sofa series. It's a virtual seminar series hosted by the Stem Cell Network that is designed to reconnect researchers and bring expert content directly to your sofa. Today's talk will be presented by Dr. Véronique Moulin. Before I introduce Véronique, I'll quickly familiarize everyone with the use of the Zoom platform, although I'm sure most of you are highly familiar with it, so I'll be pretty quick. At the top here, you have your view options if you're looking to change that, if you need to. At the bottom left, this may be important for some people, there's the audio settings. You can get in there and change the volume, etc., check if your speaker's working. You're on mute as an attendee for this, but you, as I will tell you in a moment, you can actually ask questions through the Q&A button located here. This will bring up a panel which will allow you to enter a question at any point. So please do ask questions during Veronique's talk at any point. Those questions we'll save for the end of the talk, and then Veronique, I'll read the questions to Veronique and she'll be answering them for you live. So, then I'll start the introduction here for today's Stem Cell from the Sofa. We're joined by Dr. Véronique Moulin. Following her training in France, Paris, Dr. Moulin was recruited in '98 to the Université Laval to build a better understanding of the complex processes of healing. Véronique is a professor at the Université Laval Faculty of Medicine, Department of Surgery, but also a researcher and director of the Regenerative Medicine Division at the Research Center of the CHU de Quebec. Veronique's work focuses on the normal pathological mechanisms of skin healing. To perform this, she uses different cell culture models reconstituted by tissue engineering to reproduce in vitro fibrotic skin diseases. At the same time, she uses the tissue engineering method to reconstruct cutaneous substitutes to treat skin deficient patients, including those who have suffered from severe burns. Veronique's team received funding from SCN in 2019 to expand the clinical trials that her team has been pioneering to test these skin substitutes. And today, Veronique's talk will be entitled Treating Burn Patients Despite COVID Pandemic and Social Distancing. Veronique, welcome and thank you very much. Please start your talk.
Oh, okay. So thanks very much, John.
You just need to share your screen, Veronique.
Yes, I have to. Do you see my slide?
I can see you. Off you go.
Okay. So thanks a lot. And first of all, thank you for this invitation and the invitation from the Stem Cell Network. It's very appreciated. And it's a pleasure for me to present our results that we have obtained from now more than 10 years for the treatment, during the treatment of burn patients. And we continue despite the COVID pandemic. So it's a pleasure for me to show you the last with the old result, but also the last result. Okay. So this is a diagram of skin. So you can see, the epidermis, that is the thinnest part of the skin, and this is the dermis. And what happens when you have a burn? If the burn is not so important, not too deep, the cells from the epidermis and the dermis remains, and the patient has only have to wait and to clean the wound for sure, but the cells that are present can continue to grow and continue to reproduce the skin. But what about when this burn is very deep and no more cell remains? So the problem is occurred during some time for burn patients, and the problem is very important for these patients. So and this time, the only way to treat this wound is to replace the tissue and perform a graft, and in this case, to perform an autograft. So for these patients, the surgeons removed a piece of skin from a place that is not burned, and they call the donor site, and they use this skin on the burned place to reconstitute and to cover the burns. However, what could the surgeon do if the surface of the burn wound is larger than the healthy skin? You can see here in black, it's all the burns. And for sure, you cannot use only this skin, this healthy skins to reconstitute and to cover all the body. So this problem for sure is rare, but it exists. And at this moment, the surgeons we have to wait until the donor site that has been removed for the first time. He has to wait that this site heal, and after that he can continue to remove a second time and a third time. But of course, it's a method that is possible, but takes time, so cannot be used several times. Usually after a maximum of 3 or 4 grafts, the skin cannot be longer healed. So the surgeon have to stop to remove it and to use it. So the problem is there, and at the LOX, we have tried to try to find a way to treat these patients. So the LOX, what is the LOX? It's an academic research center that is affiliated to Université Laval at Quebec City. And for more than 30 years now, we provide epidermal sheets, that's only the first part of the skin, for treating burn patients. So in parallel, we have developed bilamellar skins that contain dermis and epidermis. And to reconstitute this one, we use a self-assembly approach that has been developed on our lab that is based on the capacity of the cell to reconstitute tissue when they are cultured in the optimal conditions. So what is the method to produce skin substitutes? In fact, briefly, the skin biopsy is treated by thermolysine, that is an enzyme that allows the separation between dermis and epidermis. And, oops, sorry, I'm looking for, okay. And after separation of these 2 parts, we use other enzymes that can isolate the cell, and then we can culture keratinocytes and fibroblasts separately. After that, we can start to produce the skin substitutes. Fibroblasts are cultured during 3 weeks with ascorbic acid. This ascorbic acid is a core factor for the production of the matrix, extracellular matrix. And after 21 days, with the matrix is very important, and the fibroblasts can be manipulated. We obtain a fibroblast sheet that can be superimposed to reconstitute the dermis that is thicker. And after that, the keratinocytes are seated on the top of the dermis, and after air liquid interface culture, we will obtain a differentiated epidermis. So with this method, we can isolate skin cell from a very small biopsy from a patient, or around between 1 and 6 centimeters square. So it's not it's like a quarter, and produce a self-assembly skin substitute that we call SAS. And for the treatment of patients, of course, we produce this skin using the LOX facility that is a clean room that has been built specifically for the treatment of the patient. So when the skin substitutes are ready, we send them on the burn unit, and this skin can be grafted after debridement and proper preparation of the burn area. So this is histology of the skin substitute. You can see here the epidermis with a multi-layer of cells in pink, and beneath this is a dermis with in blue this is the extracellular matrix, and in red the fibroblasts. You can see if you compare with the histology of normal human skin, the histology very similar from the normal skin. Here you've got the microscopic aspect of the skin, the skin substitute. And you can see that it's easy to manipulate. And when we add on the patient, you can see that it's very interesting. And for the surgeons, the thing that is very interesting is that the skin substitute can be grafted following a protocol that is very similar, exactly similar to that for the that they use for the autograft transplants. So this is very interesting for them because they do not have to learn a new method to operate. It was always interesting for the surgeon. So this skin substitute has been first used to treat patients, burn patients, following a special access program from Health Canada. Following this program, we have treated 14 patients from 2005 to 2015. This patient was burned with on more than 60% of their surface area. So it was a problem to treat them using the standard procedure because of the difficulty to obtain donor sites. So the surgeon sends us a skin biopsy and we can produce skin substitute. And after that, we can send back the skin to be grafted. So this is the result, the list of the patients treated with the autologous skin substitute. And you can see here the percentage of burn surface area. Here you can see that we have from 50% to 90% of the area of the patient that was burned. And here you've got the surface that have been grafted. You can see that it was could be a large quantity. And of course, the most important thing when we treat patients that we want to evaluate if the skin substitute has been grafted and continue to be maintained. And you can see the graft type is very interesting. So the most important parameter when surgeon graft skin is the capacity or the ability of the epidermis to stay and to remain in place in long time. Of course, epithelial cells are cells that can react very strongly with immune cells, and usually when the cells are not autologous, they remain very quickly. For example, when the surgeon usually use cadaverous skin as a temporary dressing, and usually this skin are rejected after 3 or 4 weeks. Currently, the longest follow-up of the graft skin substitutes is more than 8 years, and as you can see, we never obtain any failure of this epidermis. So the graft tech is very interesting at long term. Why do we obtain this result? Because we think of course, we use autologous cells, so it's not rejected. But furthermore, we think that we can keep during a long time the epidermis on the patient. It's because our culture condition can keep the stem cell of the epidermis. You can see here 10 days before grafting and 21 days after grafting, we have evaluated the presence of keratin 19 stem cells, and keratin 19 is a marker of stem cell in epidermis, and you can see that the stem cells are remaining. So we think it's very important to keep stem cell, and it is why we obtain a survival that very interesting. Oh, sorry. So the next slide are the result obtained when we graft the patient with a skin. So here is the first patient that I want to show you the results. This is a young male that was burned on more than 90% of the surface area. And in the picture here in blue, you can see the place where we add, or the surgeon placed the skin substitute, and you can see that he has covers the surface with at least half of the surface. So he had covered half of the surface of the patient with skin substitute. Here you've got the place of the leg, or the arm of the leg just before the grafting. And this is the day with just after the grafting with the SAS here. And here's the result after 7 or 11 weeks. So you can see that the wounds are all closed and the skin is homogeneous without any pathological scars. The second patient that I want to show you is a male that was burned on more than 80% of the surface area. We have treated only 10% of the surface, but after 5 years, you can see one of this, an example of the result, and you can see that, and it was very interesting for surgeons, patient, and us. This is a place, usually in this place for burn patient, the surgeon observe a pathological scar as a hypertrophic scar or contracture. So we never observe this pathological scar in this place when we treat patient with SAS. And to explain what is a pathological scar, I add a picture of a people that was burned, and you can see this is a contracture. So this is the burn develop cord here. You can see that limits the movement of the joints, and usually people have to be reoperated. So as I say, for the moment, we never observe this sort of problem when we graft patient with skin substitute. So the last patient that I want to show you the results, it's again a young male that was burned on over than 70% of the surface area. We have really a few donor sites, and you can see we cover a large quantity of the surface. And the result I want to show you, it's the elasticity of the skin substitute after grafting. It's very interesting for everybody because the skin can usually, after if you have some scar, you know that the scar usually is more stronger and thicker than the normal skin. And you can see here after SAS grafting, the elasticity is very interesting. Same thing for joints, this place. We have no mobility reduction. However, in this patient, we observe some spot here, and we think that because this patient before burn was has a coral skin, and this spot corresponds to the melanocytes that appear, probably because some of the cells have been kept during the culture time and continue to grow and react to the sun expositions. So it's not pathological, it's normal, but it's not so beautiful that we would like to have. Excuse me. Okay. So in summary, following the treatment of these 14 patients, we have concluded that the self-assembly skin substitute could be a promising method to treat burn patients. Before grafting, the SAS is resistant, can really easily manipulated by the surgeons. During grafting, again, the manipulation is similar than for autograft, so for surgeons it's interesting. And as the SAS are produced with the patient's own cells, it's fully autologous, so we never observe any rejections. So, and of course, as we keep some stem cell in the epidermis, we observe a long-term regeneration of the epidermis. So for sure, this is very interesting. However, the special access program, yes, it's very interesting because it allows to quickly use a new method, a new drug to treat patients that cannot be cured with the actual treatments. However, this special is not a clinical trial, of course, and we are not in the obligation to evaluate the efficacy of the safety of this treatment. So we have decided to ask to Health Canada if we can start a clinical trial to evaluate the efficacy of these treatments. Oops. So in 2014, we have obtained this authorization, and we start the treatment of patients in 2015. So the principal objective of this trial, also, of course, is to demonstrate that the graft take of SAS is equivalent than those of autograft, because this is the treatment that is in this moment. And in secondary objective, we want to evaluate the quality of the scar at the graft take for sure, to compare the SAS the soft graft, and the autograft. So as for special access programs, the target population is patients that suffer from deep second degree or third degree burns, over 50% of the surface area or more. And of course, we will need some ethical authorization for each clinical site and patients. That is not true for the clinical, the special access, for example. We only need the authorization of Health Canada. So the protocol of this clinical trial, first, when a burn patient is accepted to burn unit, the surgeon has to evaluate very quickly the surface area that is burned, and if he can cover these burns with autograft. And if he decided that it is not possible, he sends us a biopsy, a little biopsy of 3 to 5 centimeters squared, and then we can start the production of skin substitute. After 7 or 8 weeks, we can send around 1,000 centimeters square of skin substitute that can graft by the surgeons. And if it's necessary, we can continue to produce each week the same surface area of skin substitute. So this study is a randomized control early phase trial. That means that we have to evaluate SAS with the control, the positive control, that is the split thickness autograft. And how we evaluate this, we have to select an area of about 100 centimeters square, and we divide this site in two. One side will be grafted with skin substitute, and the other one will be grafted with autograft. And of course, we randomize the place for each graft. Okay. So our primary outcome, of course, it's to evaluate the percentage of graft take at these 2 sites, but also for all graft sites, SAS sites. And following this first outcome, we will continue, and we want to evaluate the scar quality using different parameters. Most known is Vancouver scar scales. That is a scale that is used in burn unit to evaluate the quality of the scar. So this is very qualitative, but they evaluate the color and the thickness, for example, of the scar. When the device is available, we can also quantitatively evaluate the same parameters, the colors, the dermal thickness, and the elasticity of the skin using different devices. And this evaluation was done until 3 years after grafting. To meet the principal objective, we have estimated that the number of treated patients must be 17. So in this moment, at that time, we have 3 sites have accepted to participate to randomize patients into the trial. So the burn unit of Quebec City, of Montreal, and from Calgary. And we've got 2 other sites that are in progress at Vancouver and Toronto. We need to obtain ethical authorization to start patient treatment. And of course, we want to recruit other sites, our aim being to recruit all the burn units of Canada. So this is the characteristic of each production batch of skin substitute. Briefly, we can produce each week around 1,000 centimeters square, and the shelf life of the skin is 2 days. So they have to be grafted very quickly. And of course, we evaluate the safety of this graft using assay of mycoplasma, endotoxin, and bacteria. And the most important thing, I think, for surgeons, and we have to decrease this time, but between the day of biopsy and the day that we can send the first batch, the surgeon have to wait around 50 days. So it's a long time, so we have period, so we have to decrease it. So shipping live tissue is always a challenge. So in your case, at the beginning, we start to deliver the skin substitute at Quebec City and in Montreal. So it was not a big deal. We take our car and we ship, we send the skin substitute with our personnel. But now we want to treat all the patients in Canada. So we have to, we have decided to change our procedure and decided to use a certified air transport to send us a skin substitute. So we have developed a transport container that we can see here, and also the procedures that allow us to deliver the batch safety with a safety. And usually, if you want to treat some people that are in Vancouver, we are in Quebec City, so the transportation can be at least 12 hours or even a day. So the skin substitute has to be maintained in the good conditions to be alive before to graft. So we have developed all the conditions. It's in pink. You can see a solid medium that can continue to feed the cell during the transportation. So we, at that time, we have recruited 8 patients. We have treated 6. One is in progress actually in this moment, and one is dead before to graft. It died before to graft, and you can see the surface area of the patient that was burned was around 70, so it's a large surface, and we have the graft between 1,000 and 5,000 centimeters square of skin substitute. So yes, of course, we have evaluated the graft take, and you can see that the graft take, the difference between the graft take with between skin substitute and autograft is not very different. So we are happy of these results. We also performed some histological analysis 21 the day after grafting, and we can see that we obtained some, we can evaluate, detected some capillary into the skin. That's can be very interesting using PCAM and collagen 4 that as a marker of angiogenesis. So the skin that's never been before, then the skin before grafting have no endothelial cell. After 3 weeks, the endothelial cell are migrated into the skin. You can also see the junction between the dermis and the epidermis with a very beautiful hemidesmosome. That's it's very interesting because it's pretty difficult to obtain in vitro. So to end, this is this result that we have obtained in the past. And now, what now? Of course, during the COVID pandemic. So as everywhere in Canada, Université Laval and Research Center, the CHU de Quebec, shut down their non-essential research the week of March 16th. So, however, as a skin substitutes treatment was considered as an essential research because of the impact on patients, where the trial was not stopped by the ethical committee. So we continue to recruit patients and produce skin substitute for burns. However, of course, we have continued to produce the skin, but with a limited number of persons. We now have been back to work since the beginning of May. And we have, of course, new rules as the mask and the glove and 2 meters distanciations. However, as you can see here, this is before COVID. So there are not many differences before and during the COVID because we already have to wear some mask and glove during the productions. Of course, when in the absence of lab work, we stimulate work at home, but we are a production for patients, so we have many standard operating procedure to write and to read, so they have many things to do. However, the negative part of impact of the COVID pandemic is for the project is the stop of the procedure for obtaining ethical and administrative authorizations. The stop in all the burn units, they stop the process to recruiting new sites. Sorry. So I would like to thank everyone that work on this project, Dr. François Auger, Lucie Germain, that are the co-PI with me on this project, and also all the teams that produce or help to the productions. As you can see, there are many people, but the production of skin substitute in the hearts works, and these people are very hard people. So finally, I want to thank the financial support and especially Stem Cell Network with the Advancing Clinical Trial Program. This very interesting program that help us to send for free the skin substitute to the burn units. And I think this grant will really make a difference in the progress of our AC. And thank you for you.
Fantastic. Thank you, Veronique. I think we have time for some questions, and we have questions coming in right now. So please keep them coming as well. One question here: can you see the graft with SCIPs, so skin-derived progenitors, to facilitate hair follicles? And can something be done similar be done for sweat glands as well?
We ever try to reconstitute hair follicle in vitro? For this moment, we cannot do this one, and we don't think it's important. It's not the same, but we think that for the moment, the most important for the patient is to be covered, to eliminate the infection and the liquid to be outside of the patients. For sure, it could be very interesting to have hair and glands, but we cannot for this moment. And I don't know if any people can do this one for this moment, I think.
I suppose that linked to this is another question, which is, do the SAS regions actually just by themselves develop new sweat glands and hair follicles? Is that something you see?
After grafting?
Yeah. We
never observe this one, and this is one of the problems for these patients. They cannot sweat at this place we graft. So they have some problem to regulate the temperature, for example. Yes, it's a problem. But usually it's the same problem with autograft. Autograft, usually, yes, they've got some annexes as the sweat gland, but usually they've got less than the normal skin.
So are there particular regions of skin when transplanting that you don't wish to take from because they fare poorly when they're moved into a different area of the body?
I'm not sure that I understand.
Okay, so if you take, say, skin from a region of the leg, does it do well on the torso, or for instance, are there areas that you cannot transplant well?
Usually, yes, you can transplant everywhere, all the skin everywhere, but usually surgeons don't want to transplant to remove the skin from the head, for example, for the face, not for the head, but they don't want to use this the skin from the face, because usually the donor cell will continue to heal, but they will produce hypertrophic scarring usually. Okay. So they don't want to increase the quantity of scar of the patients. So they don't want to use to remove the skin from the hand and from the face. So it's why sometimes it's very limited, because they can have, as the first patient that I show you the result was burned on 90% of the surface, and it's around only the head was not burned. So the surface of the donor cell was very, very few.
Okay, thank you. So beautiful results. One of our attendees has written, does the innervation return to the grafts in time? Can they feel touch and temperature?
Yes, usually, I didn't show you the result, but usually patients have some touch and can evaluate. They have some nerves that grow on the skin, so they can have some touch capacity, but it's not the same that's before birth, of course. It's always a problem, but they've got some, yes.
Somebody asking here, what's the possibility of using 3D printing in the future?
Why not? We've got some people who are working on this one. I'm not sure that for the skin it's been very interesting, because for the moment, I'm not saying that in the future it's not possible, but at the moment we can reproduce very interesting skin with our technique and method. But why not? Everything is possible now, I think.
Could you imagine that it would be possible to 3D print directly onto the patient, or would you always require a culture stage?
Yeah, I know that it's possible in this moment during experimental study, and I think it could be possible. But the problem in this using 3D printing, usually the cell are not embedded with their own matrix. The problem is the environment of the cell. It's not the cell usually, and they have to demonstrate that it could be possible, but they have to demonstrate that the environment of the cell is good enough to keep the cell in place. And I think it's a problem is to keep stem cell, for example. We know that we've got some stem cell in dermis and epidermis. So we demonstrate that the epidermis, the stem cell from epidermis is in place. I hope that, and we think that the environment is important to keep the stem cell on the good place. So maybe if 3D printing can do this one, it could be possible, yeah.
Very good. So the next person, this is nice work, congratulations, they say. Where were the most significant challenges during the production of the SAS and the difficulties involved in the transportation to patients at multiple sites?
I think we have, the transportation now is okay. We have the control all the parameters. During the production, the problem in this moment is we have to stay, if we have to, the whole process of production is around 50 days. So it's very long time period. Usually surgeon would like to obtain the skin after 2-3 weeks. So we have to shorten the period to produce the skin. And we try, but it's not for this moment, it's difficult. So
and
I think it will be the highest challenge. Yeah.
So is there a future you can see for allografts to improve that timing, or is it always going to be autografts, you think?
For the moment, yes, we are expected that if fibroblasts usually are less immunogenic than keratinocytes. We know that if we want to graft allogenic keratinocyte, it will be rejected for sure. But if we want to test if we use allogenic fibroblasts with autologous keratinocyte, maybe we can, the body can accept this skin. So this is in process now. We have to test it. But for sure, if we can do this one, we can shorten the period, because a longer period to produce the skin is the production of dermis. So if we can use allogenic, you can always add dermis in process. And when we've got a patient, you only have to add some keratinocyte in the skin. It could be a possibility, yeah.
Okay. Are you evaluating chronic itch relative to other grafting techniques?
We are not scientifically evaluating itch. Yes, I know that it's a very important problem for this patient, but people usually, we ask them, and usually they explain us that they are not so itchy than the autograft, for example. But we never evaluate completely these parameters.
one more. So I don't know if this was covered during the talk. What is the size of the biopsy taken on the patient after the grafting? Does this impact the patient and or the wound healing going forward?
Usually we do not perform a biopsy for all patients, for me one patient, and this biopsy was 6 millimeters diameter, so it's very small, and this patient have no problem to heal after that.
And I guess it's really worth, since these are patients, so what are the quality of life measures that you have, and what are the reports you get back from the patients? You know, how do they fare in the long term, and how do they feel about the process?
Usually this patient have fairly good quality of life, but it depends on the patients, it depends on many things. So it's difficult to answer. And we try to evaluate if the skin substitute can increase the quality of life. But it's difficult because usually patients have some autograft and skin substitute. So it's a mix of treatment. So it's difficult to really conclude on the impact of CES versus autograft. However, we spoke about some patients, and usually this patient wants that we remove the autograft to graft skin substitutes. So we think that it's because the skin is more elastic, more supple. So usually they prefer the skin substitutes than the autograft. It's something crazy, maybe, but they prefer the 3D skin.
Really? Okay. All right, well, with that, I'm going to thank you, Veronique. I'm just going to, before everyone leaves the webinar, I just want to talk about 2 upcoming webinars that we've got. So thank you very much, Veronique, again, for a superb talk and answering all of those questions. Very informative, and we all wish you luck with the trial that you're undertaking, and clearly you're making some really life-changing impacts for these patients. So that's great. Thank you very much. I'll just move forward one slide. There we go. So next up, quick heads up for a couple more stem cells from the SOFA series talks. On June 17th, we have a trio of short talks from 3 lead investigators who were funded through SCN's COVID-19 Rapid Response Initiative in April. Doctors Muffet, Stanford, and Stewart will be providing overviews of each of their projects and taking your questions. And you can scan the QR code or visit our website on the address there to register and find out more details as well. And then on July 2nd, which is actually not a Wednesday, normally we run these on Wednesdays, but since July 1st is Canada Day, we're moving to Thursday of that week, and we're very excited to host Dr. Katie Cockburn, who's the New York Stem Cell Foundation Druckenmiller postdoctoral fellow. She works at the Greco lab at Yale University, and she's going to be providing an oversight of using intravital imaging to answer fundamental questions about epidermal stem cell biology. As always, the stem cells from the SOFA talks are posted on SCN's YouTube channel, and you can get updates on upcoming stem cells from the SOFA events and much more by visiting our website or following Stem Cell Network on Twitter. And you can follow at Stem Cell Network on Twitter there. All right, well, thank you very much, and I'll see you next time.